Dear colleague, it is my pleasure today to tell you a little bit about the surgical treatment, a new avenue potentially for NASH in the coming years. You all know, I assume, bariatric surgery or weight loss surgery, which has proved in the last couple of years to be also an unexpected treatment for metabolic disease. Here you have the very common performed surgery, at least in France and in most Western countries, from the simplest to the most complicated, gastric bunding, which is decreasing in frequency, sleeve gastrectomy, the most performed operation today in the middle, and on the right, the more complicated gastric bypass, the most efficient, but also the operation which is associated with a little bit more risk. What you might don't know is the number of patients that are operated in France each year, 50,000. That means that for the last 20 years, more than 500,000 patients have been operated and are currently followed. And that means that 1% of French adults have been submitted already to metabolic surgery in France. Why that? This is the most obvious reason, because these operations are efficient for weight loss. And most of our patients are severely obese. And so you can see on this very last issue of a famous study from Sweden, comparing a control group to matched patients submitted to surgery during 20 years, that the difference is quite striking, with important weight loss up to more than 10 kilograms per square meter, which is of course nearly 20 or more % of weight loss. And of course, there is a little bit of rebound in the first years, but after the 5th years, and especially the 10th years, it seems to be quite stable. More recently, and more strikingly, this weight loss has been associated with a very striking result on metabolic disease, including type 2 diabetes. That forces us to invent, or at least to propose, a new name, which is remission of type 2 diabetes, meaning a patient with years of history of type 2 diabetes, 2 or 3 drugs, after surgery, just seeing his blood glucose control, even able to stop any drugs for having a normal blood glucose. And this is a whole country study that was published 2 years ago now in France, but that has been also demonstrated in many countries, in many studies, and confirmed that after surgery, nearly 30 to 50%, depending on the operation you're considering, can just discontinue their anti-diabetic drug without increasing their blood glucose. So strictly speaking, being not diabetic anymore. More interestingly, if we now look at clinically meaningful outcomes in the long term, this is the last published report of an important study that was already published several times before, that appeared in the Lancet 2 weeks ago, telling us about the 10-year outcome of this randomized control trial that compared face-to-face medical therapy versus surgery. And you can see on the left, on the red, the medical therapy, quality of life, which is very poor in type 2 diabetes patients, with an important increase in surgical patients. But more importantly, on the right side, you can see the number of complications, both microvascular and macrovascular complications, that are dropped considerably, the incidence in the group of patients operated. Okay, so but what about bariatric surgery for NASH, if it's so efficient for the type 2 diabetes? So the first encounter between these two subjects were the blind date. It was several decades ago, and many of you maybe have recalls of that time, where bariatric surgery was not known as a good point in hepatic disease, with this type of case report showing drama such as steatohepatitis, but also hepatic failure or liver transplantation requirement after bariatric surgery, mainly at that time with intestinal bypass or biliopancreatic diversion. So these things were in the memories of every teams when we started to do bariatric surgery in Lille. That was in the very late years of the last century. And that pushed me when I started to induce a cohort to follow very specifically our patients for the liver, fearing at that time that we might face some drama or some complications. And that explains why in Lille, together with my hepatologist colleague, Philippe Mathurin, we have been followed very carefully in an ongoing cohort study, patients that were operated with us in the classical weight loss indications, not only at baseline, at the time of surgery, when we were performing a biopsy, but also at 1 year and 5 years, where routine biopsy, liver biopsy, percutaneous biopsy, were proposed to patients that were operated with us, together with other phenotypic evaluation. So you can see what is a biopsy for a surgeon. So you can see the needle, but from the inside. So it's quite a simple gesture, taking a few minutes in the beginning of the operation, which is routinely performed in all our patients. So here you can see the distribution of the histological features of the NAFLD in the typically bariatric patients we are facing, meaning severe obesity. The mean BMI is nearly 50 in our series. You can see that, of course, NAFLD is present in the vast majority, more than 60%. But we also see that if NASH is considered as a clinical diagnosis with a Brunt score by our pathologist, the frequency of NASH in this unselected population of severely obese patients was barely above 10%. We also saw that many of these patients, nearly 15%, had nearly normal liver, the same liver as normal liver lean controls. So during these years, because we did these longitudinal liver biopsies in more than 1,000 patients, this has stopped now because in contrary to what we expected, we didn't see any harmful events, but many very good news. We have now stopped, but during these years, we were able to describe in this prospective cohort many outcomes of surgery regarding NAFLD. So of course, the proof of concept has been published before with observational cases of double biopsy where NAFLD was disappearing or at least improving. And there is also an overall benefit demonstrated on NAFLD in a Cochrane review published in the 2010. So what we did in Lille was in this prospective cohort is mainly these 5 or 4 achievements. First, confirmed in this unselected cohort that NAFLD improved in the vast majority of patients in closed association with insulin resistance. Second, that this NAFLD improvement was sustained in the long term, at least for 5 years. We also showed that this improvement was going beyond weight loss. Weight loss is, of course, the main driver of the improvement, but it is not the only one. The disappearance of diabetes is important, but also the type of surgery can have an effect, a specific effect on the NAFLD improvement. And more recently, and I will come back to that, we show that NASH, actual NASH, was able to reverse after surgery. So complete NASH remission, that seemed like a dream when we started, but here we have the last report that was published a few months ago from our team, where we reported the 5-year prospective outcome of this longitudinal cohort in a group of patients with biopsy-proven NASH at the time of surgery. 180 patients were included, and you can see a typical example of what was observed in the same patients with the 3 biopsies performed, as I shown you before, routinely during the prospective follow-up. Baseline, typical NASH in these patients, 1 year, and at 5 years in many patients, normal or nearly normal liver. So if we now go to numbers, this is the 5 years prospective cohort study results regarding NASH evaluated as a Brunt score. You can see that, of course, in the beginning, by definition, all have NASH, and after 5 years, that was seen already at 1 year, 80%, more than 80% of patients had no NASH anymore. So that was really significant and did not decrease between 1 and 5 years. More importantly, maybe is liver fibrosis. That was not known. There were some contradictory answers in the literature. So what about liver fibrosis? Of course, here we had to wait for a longer time. But after 5 years, as you can see here, the same spectacular results were observed, where most of the patients had fibrosis, and a significant number of them, nearly half of them, significant fibrosis. you can see here that 1 year was improved, but at 5 years, at least half of the patients were fibrosis-free completely. And in most cases, fibrosis has improved. So clearly, this is very good news, but before we can embark into let's do that to many patients, not because they are obese, but because they have NASH to start with, as we're now considering this issue in type 2 diabetes, we have to remind that surgical mortality with liver disease is not, is not a simple thing. And we know all that if you're operating patients with liver disease, including mild cirrhosis with a MEL score of 8 or above, you are significantly increasing the risk of surgery, any surgery, including cholecystectomy, even routine cholecystectomy, up to 5%. So that's really something important to consider. So surgery for NASH, and I will finish with that. Let's do it. That's, of course, the obvious answer. But carefully, even if it's very appealing, as it was demonstrated for type 2 diabetes, a lot of demonstration remains to be done, comparing risk and also benefits of this strategy. And that's why there is no other way than a randomized trial. And these trials are now ongoing. The first one was submitted to the, to the registry was our trial in Lille. It's a multi-center national randomized trial that is including nearly 10 centers in France, comparing surgery versus lifestyle in patients with no indications for weight loss, BMI 30 to 35, but NASH, demonstrated NASH with biopsy and significant fibrosis. And the outcome, the endpoint, is NASH resolution at 1 year. We also have two other colleagues in Roma and Pittsburgh who have embarked into such a randomized trial. And altogether, we hope that within the next 5 years, the same demonstration can be achieved as it is now in type 2 diabetes that will allow to probably propose NASH in the potential therapies for severe liver disease, even when the weight is not, the BMI is not above 35. So when the weight loss is not the primary objective. So if I finish here, the take-home message. So NAFLD for sure regresses after bariatric surgery in close relation with insulin resistance. NASH disappears after bariatric surgery in 80% or more of cases. Liver fibrosis itself can regress if we wait enough, 5 years after surgery. And surgery for NASH, including mild cirrhosis, is still under evaluation, and we have to wait for a randomized clinical trial before we can go on. So with that, I thank you all, and of course, we'll be happy to answer any question. Thank you very much for your attention.